Good evening, everybody. Welcome to the doubt solving session of oral maxillofacial surgery. Can we have the live chats also? Rishabh? If we can have the live chats also, ताकि I can interact. ये लर्न मोर हटा दो. ये लर्न मोर हटा दो. लर्न मोर आ रहा है ना नीचे.
मैं वो नहीं आता, वो तो अपने आप जो टाइप करेगा तो ही आएगा ना, उसमें लिखा होगा.
लर्न मोर वाला हटा दो.
वो हट नहीं सकता.
नहीं हटेगा. ठीक है, उसके नीचे से आएंगे. ओके. All right. Okay, so welcome to the live doubt clearing session. I have got around 8 doubts. All of these doubts are very nicely in detail. All these topics, all these concepts are already covered in the video lectures and in the live class. Okay, I will tell all the doubts once again. I will clear all your doubts. But just to reiterate, all these doubts, all these topics are very nicely covered in the video lectures, very nicely covered in the live class. Still, if you have doubts, you're welcome. And let's start with one question. Question number 1. So, Dr. KK has raised this question. Okay, I'm purposefully not taking the correct full name. How to get more common in exam? So this is the most difficult question I have ever faced from a student. How to get more common in exam? So maybe you can give NEET exam 10 to 12 times. Every year you choose the same center so that the examining people or the people in the exam center, they remember your face. And they start saying that this is the most common boy or most common girl in the exam. So that is how I feel. You can get the most common in exam, and this is all I could interpret from your question. तो डॉक्टर KK, ये आपका क्वेश्चन है. मुझे यही समझ आ रहा है आपके इस डाउट से. How to get more common in exam. This is exactly what happens जब आप क्वेश्चंस रिकॉल करते हो. कोई भी, anybody, any student who is recalling questions, okay? ये आपके मन की बात है. This doubt is from your heart, and this is how you put it. Sometimes मतलब हम अपनी मन की बात भी clearly नहीं कह पाते हैं. So एग्जाम में जो एग्जामिनर के मन का क्वेश्चन है जो आप स्क्रीन पे पढ़ रहे हो, उसकी भी लैंग्वेज कुछ इसी तरह की होती है. Okay? This is an actual doubt from an actual student from our academy. So I know this happens. वो क्या पूछना चाह रहा है और वो क्या टाइप कर रहा है. There is discrepancy in that, and so the sense of the question goes away. Okay. Many a times this happens जब questions recall करके students बताते हैं और वही questions, those improperly recalled questions are asked typed in the book. They are answered by giving some answer, and then students get confused. जैसे मैं हुई हूँ इस question को पढ़ के. ठीक है? So don't run behind learning the options A, B, C, D. Don't run behind learning the answers. Understand the concept. Practice the previous papers. इतना ही करना है. कॉन्सेप्ट को समझ लो और अपने कॉन्सेप्ट के बेस पे आंसर करो. ठीक है? और उस आंसर करने की प्रैक्टिस डू इट फ्रॉम द रिलायबल सोर्सेज ऑफ PYQs, वरना यही होगा. हाउ टू गेट मोर कॉमन इन एग्जाम, एंड यू विल बी द मोस्ट कॉमन पर्सन इन एग्जाम. So Dr. KK, This is the best answer I could gather by reading all the different case reports and all the standard textbooks. Beyond this, I'm unable to help you. And if you have a proper question, please send it across to me on my personal chat and I will really help you. If you're asking about the most common questions asked in exam, we have done a separate YouTube session on the most common or the most important MCQs for NEET. There's a proper series in our DBMCI YouTube channel. You can go and watch that series and you will be helped with that. Coming to the next question, maximum dose of LA in a 70 kg male. The student asked me, ma'am, I am not able to solve the numericals in LA, and this is the kind of example that she gave me, she or he, whoever the student was. So like I always say, you have to remember only 5 things in local anesthesia, okay? Only 5 things. First, 2% lignocaine. What is the meaning of 2% lignocaine? 2% lignocaine means 2 gram lignocaine in 100 ml solution. This is the meaning of 2% lignocaine. 100 ml. Why 100 ml? Because percent. Cent means 100. Okay, so 2 gram lignocaine in 100 ml solution, which is the same as 2000 milligram lignocaine in 100 ml solution. What is the solution? The final local anesthetic solution, which has carrier, which has water, which has adrenaline, which has thymol, which has methylparaben, all the things together. There is 2 gram lignocaine in every 100 ml of the solution. Okay, so this is first fact which you have to remember. Second fact, when we say 1:1 lakh adrenaline or 1:80,000, 1:2 lakh, when we say this concentration of adrenaline, इसका मतलब क्या होता है? The meaning of this is there is again 1 gram adrenaline in 1, 2, 3, 4, 5 ml solution, okay, or 1000 milligram adrenaline in 1, 2, 3, 4, 5 1 lakh ml solution. This is the meaning of 1:1 lakh. Third thing which you have to remember is maximum recommended dose. Maximum recommended dose for lignocaine and articaine is 7 mg per kg. Okay, this is with adrenaline, and of course without adrenaline is 4.4 mg per kg. Most of the times this will not be asked. This will be asked because this is a more common dose, and most of the times we give lignocaine with adrenaline in most of the clinical situations. So remember, maximum recommended dose of lignocaine is 7 mg per kg. Fourth fact which you have to remember is volume of cartridge. So most of the local anesthetic solutions, cartridge, are now available in a cartridge form, and the volume of one cartridge is 1.8 ml. In India, we still have vials, but cartridges are also available, especially of articaine and such drugs. So volume of cartridge is 1.8 ml. And fifth fact, just so that the examiner is not able to trick you, 1 kg is equal to 2.2 pounds. Maybe the examiner tells you that it's a 50-pound patient or it's a 40-pound patient. You know all the numericals, but you just don't know how to convert pound to kg. So for that extremely rare situation, just remember 1 kg is almost, a kg is almost double of a pound. So 2.2 pounds make a kg. So ye 5 facts, if you remember, you will be able to solve all the numericals of local anesthesia. Okay, one example I will give you. 3 ml of LA solution contains 2% lignocaine with 1:1 lakh epinephrine. How many milligrams of each are present in the solution? Okay, so very easily let's start with adrenaline. let's start with lignocaine. 2% lignocaine means 2 gram lignocaine in 100 ml solution. Means 2000 milligram in 100 ml solution. Okay. So 100 ml में 2000. So how many ml do we have? We have 3 ml solution. So how many do we want in 3 ml? 3 ml में x is equal to 2000 into 3 divided by 100. So this is 60 milligram lignocaine in 3 ml solution. Okay, so it can be either option B or option C. Okay, so you have calculated कि कितना lignocaine होगा. Now 1:1 lakh epinephrine. 1:1 lakh means 1 gram adrenaline in 1 lakh ml solution. That means 1000 milligram in 1 lakh ml solution. So in 3 ml solution, how much will we have? X is equal to 3 into 1000 divided by 1, 2, 3, 4, 5. 0.03 milligram. So this wrong, this correct. So C becomes your answer. So that is how you calculate. Okay. Agar now you have to find that, you know, how many cartridges can you give? How many cartridges of lignocaine can you safely give if it is a 70 kg adult? Okay, that was your question. So if the question says it's a 70 kg adult, and how many cartridges can you give? So cartridges are calculated based on the weight of the patient. The safe dose of lignocaine is 7 mg per kg. आप 7 mg per kg lignocaine दे सकते हो if you are giving it with adrenaline. Okay, so 3 ml में 60 ml है. So 1 ml में कितना है? 1 ml में 20 mg adrenaline lignocaine है. 1 ml has 20 mg lignocaine, obviously, because 3 ml has 60, so 1 ml has 20. So 20 mg is there in 1 ml. 70 kg adult can have 70 into 7 is equal to 490 mg lignocaine. Okay, so 20 mg is in 1 ml. So 490 mg will be in how many ml? Very simply, it will be 490 divided by 20, which is around 2 2s are 4, 2 4s are 8, 24.8 ml. 24.8 ml solution you can give to this patient. Okay, now one cartridge has 1.8 ml. Okay, so 24.8 by 1.8, which is equal to 13.6. So you can give around 13-14 cartridges safely in this patient. Okay, that is how you calculate the number of cartridges. Usually we don't require that large amount. It is just for the sake of calculation, which is why the examiner will not usually ask you this cartridges wala question. Okay, because it comes out to be a very big number. Usually our purpose is solved with, suppose, but if you want to do a bilateral BSSO, where you have to give the patient is under general anesthesia, but for the multimodal analgesia you want to give local anesthetic also, so you have to restrict yourself to 13.6 cartridges or around 24 ml of solution. That is how you calculate the number of cartridges. Okay, and just in case the question is asked in pounds, you know how to calculate pounds to kgs. Okay, that is the second question. Now the third question is, all those who are posting questions now, it's a little too difficult to take all these questions and I cannot really explain concepts. Somebody is asking me space infection. Go to the videos, watch space infections. I cannot explain a full topic. I can only clear certain doubts in that topic. You can go and watch the full video from the recorded videos, okay? The next question was prophylaxis or management for various disorders. Okay, again, this is not a doubt. I have very nicely explained how to manage individual patients with individual diseases in the medical comorbidities section of our recorded videos. You can go to LA. In the LA, you will have medical comorbidities. In that, every single disease has been explained by me in detail. Please go and watch that. In very brief, I'm going to tell you how you decide what steps you will take or what precautions you will take in any patient. Okay. As a surgeon, you have only 3 concerns. Okay. First concern is emergency. Whether your elective procedure will convert into an emergency. Why will that happen? Steroid crisis. Patient is on steroid. His HPA axis is suppressed. You are not supplementing steroids. He will go into a steroid crisis. Thyroid storm. A patient is hyperthyroid. You have not evaluated the patient properly and he's not taking medication and you are giving an LA with adrenaline. Thyroid storm. So emergency nahi honi chahiye. Any patient who is taking drugs and is managing his disease is just like you and me. He's just a normal patient. Any hypothyroid patient who is on medication is euthyroid, is normal. Proceed normally. Any hyperthyroid patient who is taking propyl thiouracil and is under treatment and is T3, T4, TSH is normal is euthyroid, is normal just like you and me. Any patient on anticoagulants with a PT-INR, APTT within the normal range is a normal patient. You can treat him normally. Okay. Any patient with kidney disease. Now it's such a vague thing. When you ask me kidney disease, a kidney disease can be an acute kidney injury. It can be a chronic kidney disease. It can be a patient on hemodialysis. It can be a patient on who is a post-transplant, post-renal transplant. So it is very, very vague. Please go to the videos, watch the videos and understand what all things can happen to a kidney disease patient. And examiner कभी भी आपको ये नहीं बोलेगा patient को kidney disease है, आप इसका दांत निकाल के दिखाओ. No, he will tell you the situation. He is a patient on kidney disease with this problem. So accordingly you have to manage. So first concern for a surgeon is emergency nahi honi chahiye. It should be an elective thing. It should go smoothly. Second concern to any surgeon is intraoperative and postoperative bleeding. Okay. Most of the time, when we are doing small procedures like tooth extraction, curettage, gingivectomy, small procedures, excision of some small mucocele or an epulis, bleeding is usually managed in most of the times. Okay. When you have to be concerned about bleeding is when you are doing a major surgery. When you are taking a surgery for under GA, for BSSO, for a cleft, for a fracture or for a pathology, when you are doing major surgeries. That time you have to see what is the bleeding profile of the patient. Whether the patient has any bleeding disorders. In that case, individual disorders has to be treated according to the medical management of that disorder. Whether the patient is on antiplatelet drugs. Antiplatelet drugs, mainly aspirin and coumarin. Usually, you divide it into a minor surgery and a major surgery. When it is a minor surgery, you do not stop antiplatelet medication, whether it's a single antiplatelet or whether it is a dual antiplatelet. Maybe the patient is on ecosprin alone or the patient is on ecosprin plus clopidogrel. Whether it is a single antiplatelet therapy or a DAPT, dual antiplatelet therapy, you don't need to stop the medication. You can do the minor surgery along with the antiplatelet medication and the minor bleeding that happens can easily be managed. But when you are doing a major surgery where a lot of blood loss is anticipated, you have to stop your antiplatelet drugs 3 to 5 days before surgery. Minimum is 3 days, what most of the articles and most of the books say, it is minimum is 3 days. 3 to 5 days is ideal because of the 10 days is the half-life of a platelet and the action of the drug which stays in the circulation. Okay, so that is the second thing, antiplatelet drugs. Third is anticoagulants. Anticoagulants, again, they're of two types: warfarin type, which acts on the prothrombin type, and heparin, which acts on the APTT. So depending on whether the patient is on warfarin or he is on heparin, most of them hospitalized patient can be on heparin because it is given subcutaneously. Most of the at-home patients are on warfarin because it's an oral drug. So depending on which anticoagulant he is on, you will perform the test. If the test reports are within normal range, you can proceed. If they are beyond, you have to bring the INR of the patient, and the safe range for INR is less than 3.5. If the INR is less than 3.5, you can perform your extraction, you can perform your minor surgery. If it is more than 3.5, you have to go for something which is called the bridging therapy, and everything is discussed in detail in the videos. Okay, whoever has raised these doubts, beta, these are concepts, these are not really doubts. So you need to really make your concepts clear and proceed with answering the question. Okay, so this is the second concern that comes to a surgeon when he is operating on a patient. The third concern is post-operative wound healing. Okay, so I am a surgeon. Do no harm comes before do good. Okay, so जब मैं सर्जरी कर रही हूँ तो मुझे पहले ये सोचना है कि ये जो wound होगा, सर्जरी से जो wound create होगा, whether it will heal or not, whether it will heal normally or it will not heal normally. Okay, any patient who is on chronic disease or who is on immunosuppressants or who has an organ transplant, his healing will be affected. A patient who is diabetic, we know diabetes mellitus is one disease which causes poor wound healing. So patient who is diabetic, patient who is on chronic steroids, because we know that steroids cause immunosuppression. Immunosuppression means his immunity is not able to tackle the post-operative wound, the post-operative infection, and there can be post-operative wound dehiscence, sepsis, so many things. Third thing, if a patient is on immunosuppressants, there's a whole list of these things. I'm just giving you a superficial review. Immunosuppressant कौन सा patient ले रहा होगा? Immunosuppressant patient who has autoimmune disease. Any patient who has autoimmune disease, he will be taking immunosuppressants because his immunity is exaggerated. It is causing harm to the body. To suppress that, the doctor has prescribed immunosuppressants. Most common immunosuppressant is steroid only. Other than that, there are many. So autoimmune diseases, immunosuppressants. Organ transplant patients, liver transplant, corneal transplant, renal transplant, cardiac transplant, liver transplant, any patient who has had an organ transplant, he will be on immunosuppressant. So organ transplant से problem नहीं है, प्रॉब्लम है जो इम्यूनोसप्रेसेंट ले रहा है, उसकी वजह से his post-operative wound healing will not be as good as any normal patient. So patient who is diabetic, patient who is on steroids, patient who is on immunosuppressants, patient who has hepatitis, HIV or any chronic disease, okay, I will be concerned about the post-operative wound healing. In such patients, I will want to give antibiotics more aggressively, maybe a pre-operative also, and of course post-operatively. So depending on what is my concern, similarly CHD, you have asked me about cyanotic or congenital heart diseases. So there is a proper list, okay, people have researched, the AHA has researched and they have given a proper list. So which CHDs need prophylaxis? So there are only few, 1, 2, 3, 4, 5. You just have to learn these 5. ये 5 अगर आता है, then you have to give prophylaxis for infective endocarditis, because I will be worried about post-operative wound healing, post-operative infections, not just wound infections but also cardiac infections. So आई प्रोफिलैक्सिस आप कब दोगे? सिर्फ ये 5 सिचुएशन में. किसी भी CHD में आप नहीं दोगे. रिपेयर्ड साइनोटिक कॉन्जेनाइटल हार्ट डिजीज which is functioning fine in the last 1 year, you will not give any eye prophylaxis. सिर्फ इन 5 situations में you will give prophylaxis. Okay, and the purpose is same. The purpose is post-operative infection, post-operative wound healing. Okay, कौन सी प्रोसीजर में आप दोगे उसकी भी लिस्ट है. कौन सी एंटीबायोटिक प्रोफिलैक्सिस आप दोगे, कितने टाइम पहले दोगे, everything is there in the list. You just have to remember certain facts for each disease, and so you will be able to answer such questions. If you really want more details, you can go back to the recorded videos and watch it. Okay, these doses are very, very important. They will ask you the child dose, they will ask you the adult dose, they will ask you the timing. Clindamycin has been replaced with cephalexin. Everything, all these facts will be asked to you, and these tables are there in the PYQ sections many times, in the GTs many times. All you have to do is just remember these facts. Okay, next question which came to me was, which pathological cyst and tumor need resection of bone and which can be managed with marsupialization? Again, this is a clear concept based question. First, let me tell you that pathologies, you cannot combine cyst and tumor in the same pathological treatment. Okay, they are very different pathologies. Cyst अलग चीज होती है, ट्यूमर अलग चीज होती है. दोनों की एटियोलॉजी अलग है, दोनों की पैथोजेनेसिस अलग है, हेंस दोनों का ट्रीटमेंट अलग है, दोनों का नेचर अलग है, इसीलिए दोनों का ट्रीटमेंट अलग है. व्हाट इज सिस्ट? सिस्ट इज मोस्टली अ बिनाइन प्रोसेस विच इज जस्ट कुछ एपिथेलियल सेल्स हैं जो गलत जगह पे आ गए, एंड दीज एपिथेलियल सेल्स proliferate, they keep proliferating. The inner cells keep dying. As they die, they form liquid. So a fluid-filled cavity which is lined by an epithelium, which keeps growing because of the osmotic pressure of the adjacent tissues. That is a cyst. The treatment for cyst is just cut the osmotic pressure. जो वो adjacent फ्लूइड एडजेसेंट टिश्यूज से फ्लूइड खींच रहा है और फ्लूइड खींच के ग्रो किए जा रहा है. ओके, इट इज जस्ट पुलिंग फ्लूइड बिकॉज ऑफ ऑस्मोटिक प्रेशर. इट इज पुलिंग फ्लूइड फ्रॉम द एडजेसेंट टिश्यूज एंड इट इज ग्रोइंग because of that osmosis. The treatment for cyst is targeted at putting a full stop to that osmosis. Now how can you put a full stop to that? पूरा का पूरा cyst निकाल के बाहर फेंक दो, ना रहेगा सांप बांस, ना बजेगी बांसुरी. Okay, enucleate the cyst, take it out in toto. So that is a treatment for cyst. Just take out the cyst. Okay, because जो भी है उस epithelial lining के अंदर है. There is no disease, there is no pathology beyond that epithelial lining. Beyond that epithelial lining, everything is normal tissue. That is how you define a cyst. Okay, so you take it out in toto. अगर आपको लगता है बहुत बड़ा cyst है, पूरा में अगर suppose this much of my mandible is involved in the cyst and I remove it in toto, my mandible can fracture. So what I will do, I will just open a window. What I will do is, I will open a window in the cyst. Okay, and I will let all the fluid come out. तो जब सारा फ्लूइड बाहर निकल जाएगा, that means there is no osmosis. बाहर से खींचेगा ही नहीं, जो भी खींच रहा है वो बाहर चला जा रहा है. So that osmosis process is stopped. That is called marsupialization. You open the cyst, you pack it and you let all the fluid come out. Slowly क्या होता है, वो epithelial lining को खाना नहीं मिल रहा है. That epithelial lining is not getting any food which it was getting initially because of osmosis. So खाना नहीं मिल रहा है, वो shrink कर रहा है. It is shrinking. Slowly the cyst becomes smaller. And जो normal tissue है, जो normal bone है आपका, जो resolve हो गया था, धीरे it reforms. So that is just preventing a pathological fracture in the bone. So you marsupialize the cyst, you let the bone grow slowly, and when it becomes safe, you can just enucleate the residual cyst, which is called Waldron's procedure. Marsupialization followed by enucleation. So ये सारा treatment जो है, ये सारा treatment है cyst का. It is not a treatment for tumor. Okay, cyst confined within the epithelial lining. As soon as it goes beyond the epithelial lining, as soon as it starts to infiltrate, it becomes a tumor. Infiltration नहीं होता cyst का. Cyst is within the epithelium. When it goes beyond the epithelium into the adjacent normal healthy tissue, it becomes a tumor. A benign or a malignant mass of cells that is autonomous in growth and which infiltrates into the adjacent tissue. इसमें अगर आप enucleate करोगे तो कुछ ना कुछ छूट जाएगा. Some cells will be remaining behind and you will not be able to remove all the pathology, which is why we need resection. Okay, which is why you just can't remove the tumor. You need to remove a margin of normal looking tissue. Okay, if it is a benign tumor like an ameloblastoma, there is a set protocol. You will remove 10 to 15 mm, which is the same as 1 to 1.5 centimeter of adjacent normal bone, which is not really normal. It is looking normal clinically, but it has infiltration of the tumor, plus the next anatomical barrier. That is the protocol for treatment of a benign tumor. For treatment of a malignant tumor, again the protocol is very different. You have to do surgery plus minus chemo and radio, depends on what tumor it is, what stage it is, how much it has metastasized and everything. Okay, so to answer your question, no tumor can be managed with marsupialization. Marsupialization is not at all a treatment for tumor. Marsupialization is a treatment for cysts only. You cannot treat a tumor with marsupialization. If you want to know the different types of resection, we have discussed the gold uptron marks terminologies for the different types of en bloc resection, segmental resection, continuity defects, discontinuity defects, disarticulation defects. Everything is there in the videos. Please go back and understand those very nicely. Okay, so that was the other doubt which I got. Difference between subluxation, internal derangement and dislocation. Again, this is very, very conceptual. It is not really a doubt. It is a concept that you need to understand. This is my mandible. This is my articular eminence, this is my joint, and this is my articular disc. Okay, or let me show you a very nice video. Just let me show you this video. Okay, so see, I will show you the normally functioning temporomandibular joint. Okay, just watch this video. So you can see here, this white bone is your articular eminence. This lower bone is your mandibular condyle. In between them, this biconvex disc-shaped articular disc. Okay, this is your normally functioning temporomandibular joint. There is initial slight rotation. Translation is starting, then complete translation. It comes beneath the articular eminence, does not go beyond the articular eminence, and it comes back to its normal position. Okay, so this is what is your normal translating mandibular condyle. Okay, when it goes beyond the articular eminence and the patient is able to reduce, the patient is able to reduce it back, it is called subluxation. When it goes beyond the articular eminence and the patient is unable to reduce it back to the normal position, it is called dislocation. Okay, subluxation and dislocation are hyperextensively mobility disorders, which cause what is called as open lock. That means the patient's mouth is open and it is locked in that position. Patient is not able to take it back or able to take it back with difficulty, which is subluxation. So this is called open lock. Internal derangement is a very different thing. It causes something which is called as closed lock. Patient is unable to open the mouth fully, okay, because now what is happening is the disc is inhibiting the movement of the condyle. Again, watch this video. The second video is for your internal derangement. So this is your normally functioning disc and condyle. Okay, in normal situation, okay, so this is your normally functioning disc condyle. Okay, when the patient opens his mouth, the disc moves along with the condyle. It is always moving in congruation with the condyle. ऐसा नहीं होता कि condyle अलग जा रहा है, disc आगे जा रही है, बाद में जा रही है, नहीं. जैसे जैसे condyle move कर रहा है, अगर condyle rotate कर रहा है, तो disc वहीं पर है. अगर condyle translate कर रहा है, तो disc भी translate कर रही है. आपने पिछले वीडियो में भी you have seen how they are moving in congruation. See, you can see in this video also, they are moving in congruation with each other. Internal derangement में क्या होता है? This disc is prolapsed because of the pull of this lateral pterygoid muscle, because of any reason, because of trauma, because of some stressors, because of some muscle dysfunction, whatever is the reason, the disc is pulled anteriorly. तो disc उस condyle के आगे आके फंस गई है. It is stuck there and it is unable to move any further. It is unable to come anteriorly, so it is causing a closed lock. That is called internal derangement. Internally within the joint, there is a derangement of motion of the condyle. That is called internal derangement of condyle. Okay, there are different stages of this problem. There are different classifications: early reducing, late reducing, non-reducing, with degenerative changes. There's a proper Wilkie's classification which you need to know. So ये बहुत अलग-अलग concepts हैं बेटा. If you are asking me basic difference, this is the basic difference. To go into deep, you have to watch the videos. Okay, so these are two different types of disorders. Very quickly, let me show you hypermobility disorder. So you can see here, this is my glenoid fossa. Okay, if you see, this is the glenoid fossa, this is the articular eminence. Normally the condyle should translate only till here. Okay, till here. But what is happening in dislocation? Condyle is coming way beyond the articular eminence. फंस जा रही है, articular eminence के आगे आ गया और फंस गया है. Now it is not able to go back. Okay, if the patient can manipulate his mandible and take it back, it is called subluxation. If the patient cannot take it back, it is called dislocation. Okay, and the X-ray, this is how you will see it. So this is your glenoid fossa, कहाँ छूट गया है? This is your articular eminence and this is your condyle, way beyond the articular eminence. It is bilaterally in this case and excessive mouth opening, excessively wide mouth opening which the patient is not able to close. Open lock, locked jaw, open lock. Okay, this is the CT image where you can see this is the glenoid fossa, this is the articular eminence and this condyle ये यहाँ तक आना चाहिए. Maximum it should come till here, but it is translating beyond it, dislocation. Okay, same in the sagittal section also. Okay, next question that was asked to me, it was stability of various orthognatic surgeries. Again, there is no concept behind it. We have discussed it in detail in our videos. Just to give you the list, 3 surgeries are very, very stable because there is no occlusal disturbance, there is no muscle pull. They are maxillary impaction, mandibular advancement and genioplasty. Okay, so maxilla up is very easy to remember. Maxilla up, mandible forward. Okay, so maxillary impaction or maxillary upward movement, mandibular advancement, or to take the mandible forward because आगे लाने में restriction नहीं है, पीछे ले जाने में there is a pterygomasseteric sling which is causing restriction. So that is a very unstable surgery. Forward is not unstable surgery. Third, genioplasty. Any type of genioplasty, reduction, advancement, double sliding, tilt correction, any kind of genioplasty is very, very stable. So these are the most stable surgeries. Okay. Opposite to them, just remember this list, opposite to them are the least stable. Okay. Mandible forward is very, very stable. So mandible setback, very unstable. Mandible impaction was very, very stable. Now taking the maxilla impaction, very, very stable. Taking the maxilla down, very, very unstable. Opposite surgery is very unstable. And third thing is widening of maxilla. If you're doing it by orthognatic surgery, it is really unstable because you are actually cutting the maxilla into two-piece maxilla. Leafort 1 करके आपने एक maxilla को cranium से separate किया है. Now you're splitting the maxilla in the middle and widening the maxilla. That makes it a two-piece maxilla where it's a lot of control that is required. It's a lot of blood supply correction, blood supply manipulation that is required, and it is very, very unstable. So it is better to do a distraction to widen the maxilla rather than doing an orthognatic surgery. Put a hyrax, do a sarpe and distract the maxilla to widen it. So unstable, these three surgeries. Most stable, opposite. Okay, so this is how you can remember the stability of various orthognatic surgeries. Nobody is going to ask you beach ka. They will either ask you most stable or they will either ask you least stable. Okay. Okay. One of the questions was comminuted fracture, which is a better treatment, ORF or close reduction, which is better. So always remember, bone se bone milana is not at all a goal of fracture management. Okay. Especially mandible and maxilla. Craniofacial skeleton, the purpose of fracture treatment is not to perfectly align the bones. No, that is not a goal. This is the list of goals and nowhere in the goal is कि भाई bone से bone मिलना चाहिए. नहीं. Occlusion stable होना चाहिए. Okay. Mouth opening normal होनी चाहिए. Mandibular movements normal होनी चाहिए. Future में कोई growth restriction नहीं होना चाहिए. टेम्पोरोमैंडिबुलर डिसऑर्डर्स नहीं क्रिएट होने चाहिए आपके ट्रीटमेंट की वजह से या फ्रैक्चर की वजह से. एंड दीज आर द गोल्स ऑफ द ट्रीटमेंट. ठीक है, बोन से बोन मिले या ना मिले फर्क नहीं पड़ता. सो ऑलमोस्ट ऑल फ्रैक्चर्स ऑफ मैंडिबल कैन बी ट्रीटेड विद क्लोज रिडक्शन एंड ORF. So close reduction is a proper treatment for almost all fractures, including comminuted fractures. ठीक है. Now I will ask you, I will show you some images. What kind of a fracture is this? It's a comminuted fracture where the pieces are still intact. They are there. They are attached to the periosteum. They are almost in their place. Only there is a crack. Okay? You can do IMF or you can put a plate. IMF is also correct. Plate is also correct. Now when the examiner says comminuted fracture, वो define नहीं करता है क्या ऐसा combination है. So I'm giving you all the examples. यहाँ पे you can do both things. What about this? This is also a comminuted fracture where the occlusal segment is relatively okay, but this segment that is separated from the superficial bone. Now what? This is also comminuted fracture. Now what will you do? Again, you can do both. Both are correct. IMF is also correct. ORF is also correct. ORF means you will put small plates and bring these fractures together. Then you will put a big recon plate and bring everything together. That is also correct treatment. Absolutely correct. Or you can just leave it like that with an IMF because they are all held together by periosteum. भाई fracture होके खिसका है but periosteum तो है ना, तो periosteum से क्या होगा, new bone formation हो जाएगी यहाँ पे. Wherever there is a defect, it will be a prolonged IMF. Normal IMF 4 to 6 weeks का होता है. This will be a more prolonged IMF. It can be 8 weeks or 10 weeks. So that is defect में भी bone बन जाएगा. And we all know that mandibular remodeling can happen all the life. So remodeling होके ये shape भी normal हो जाएगा. So both treatments are correct. The only difference is IMF will be prolonged. It will be, instead of normal 4 to 6 weeks, it can be 8 weeks, 10 weeks, 12 weeks, depending on how far the segments are. तो ऐसे केसेस में पेशेंट यूजुअली बोल देता है कि आई डोंट वांट दैट लॉन्ग एन IMF ऑफ 3 months, 4 months, do an ORF and finish my treatment. That is how you choose the treatment. This is also comminution. Same thing, you can do both things. This is also comminution. ये IMF से भी treat हो सकता है. You can very well, everything is fractured. IMF से if you can correct the occlusion, you can just let the other bones heal normally. Only thing is IMF will be of a longer duration. That is it. Or if the patient says नहीं मुझे IMF नहीं चाहिए, just do my surgery and finish the treatment in 1 week, 2 weeks. You simplify the fracture. You do simplification followed by rigid load bearing fixation. That is obviously, again, it is a correct treatment. Both are correct. Okay. What about this? What kind of a fracture is this? Again, it's a comminuted fracture. Okay. This kind of comminution is what we call as bag of bones. What is the meaning of bag of bones? What is the bag? Periosteum is the bag. Okay. ऐसे cases में the only blood supply to these fragmented pieces are the periosteum. Okay, periosteum is the only blood supply that is left. It is like the mandible is put in a bag and it is hit and small pieces are created. So this is a bag of bones. Okay, if you feel that periosteum is intact and the blood supply of these segments can be preserved, then you treat it like a bag of bones and you do an IMF. If you feel in no way these pieces can be salvaged, like if it is an infected comminuted mandibular fracture जहाँ पर blood supply भी नहीं है, infection भी है, एक bullet भी पड़ी है, so much comminution is there, then you will go for surgery. Surgery will usually be in 2 stages. First stage will be debridement, plus you will put a plate. Second stage will be you will put some graft. Plate will obviously be a load bearing rigid plate, and in second stage, for reconstruction of that defect of whatever debridement you have done, there will be a defect which could not be saved. For that defect you will put a graft. Okay, again it's a surgeon's preference depending on the case. If it is broken into 4-5 big chunks, I will do ORF in the same sitting. I can also do IMF if I am able to control my occlusion, if I am able to get a proper occlusion. If it is a grossly comminuted high velocity injury with periosteal rupture, if the examiner is putting such type of words, periosteal rupture, periosteal stripping means कोई भी blood supply उस segment की नहीं बची है. So, if such small necrotic pieces of bone are there, you have to debride. There is no blood supply remaining. You have to debride everything. You have to treat it in 2 stages. You have to debride, put a plate. When it is healed, when there is no infection, then you can put a graft. So that is how you have to understand the language of the question. Okay, how many segments is the comminution and what is the status of blood supply? Okay, blood supply किससे आती है? Blood supply inferior alveolar nerve से आती है. ठीक है, वो तो obviously फट गई होगी क्योंकि इतना combination it must be ruptured, and it comes from the periosteum. So if the examiner is using the words like periosteal rupture, periosteal perforations, then you have to go for 2-stage procedure. You have to rebride all the necrotic small bones because इनको blood supply नहीं है, ये कभी भी वापस alive नहीं होंगे. These will die and these will cause infection. Okay, so this is how you have to answer. If there is a periosteal rupture, go for 2-stage procedure. Debride, let it heal, and do a grafting in 2nd stage. Understand the language of the question. Okay. The next concept that was asked to me again, areas of compression and tension in mandibular fracture and mini plate fixation at angle fracture. Again, beta, this is not a doubt. This is the full concept. Very quickly, let me explain it to you. Mandible is not a straight bone. It's a boomerang shaped bone. So there are multiple areas of tension, multiple areas of compression, and a central area of torsion or twisting forces because of the anterior digastrix, okay, supraoid muscles. So everything is pulling the mandible here and there. It is, अगर यहाँ fracture होगा तो digastric नीचे खींचेगा, अगर यहाँ fracture होगा तो masseter और medial pterygoid खींचेगा. So everywhere in the mandible, because of the different direction of muscle pull, there are different areas of tension and compression created. In general, it is the superior border which where a tension is created and an inferior border where a compression is created. How? I will give you example of angle fracture since you are asking me about angle fracture. Okay. So this is the normal situation. जब chew करते हैं, when we chew, there is force on the anteriors, there is force on the molars. All these forces create a tension on the superior border. Okay, and a compression on the inferior border normally when there is normal non-fractured mandible. Now when there is a fracture, ये fracture है. If the patient is not chewing, nothing is going to happen. But when the patient is in function, when the patient is occlusal loading, okay, obviously when the maxillary and the mandibular teeth will occlude, the distal segment or the tooth bearing segment will move. Okay, so this segment which has the teeth, it will move. Since it is not united to the lower, since there is a fracture and it is not united to the posterior segment or the proximal segment, this part will open up because occlusion is there on the superior border. So occlusion and occlusal forces, occlusal loading, chewing, all these things will cause separation of the distal and the proximal segment at the superior border. Okay, obviously अगर superior border से separate हो रहा है तो inferior border में compression होगा. So there will be compression in the lower border and separation in the superior border. Now angle पे you all know it is not a straight bone. Angle में the mandible curves like this, like this. Okay, there is an angle which is formed. Depending on the age, the angle is formed. Okay, now in the angle you cannot put a straight plate. You have to put, because of that angulation, you have to put an S-shaped, propeller-shaped plate, okay, which is exactly what we do in angle. If you put a plate on the superior border, it will take care of your tension and your functionally stable fixation will happen. The patient will be stable, the mandible will be stable during function. Function means occlusal loading या फिर chewing. Okay, if you put a plate on the lower border, it will not be a functionally stable fixation because tension तो वहीं का वहीं है. You are not taking care of the tension और compression में आपने और compress कर दिया. So there is no point. Which is why, with an example I will show you, if there is an angle fracture, first thing you will do is, like any fracture, you will stabilize the occlusion. Since it is an undisplaced fracture, we have put IV eyelets. Using IV eyelets, we will put wires like this and you will do an IMF. After you have done your IMF, you will put a plate. The shape of the plate will be like this. It will be an S-shaped plate. So, because this is the superior border of the angle region. From the lateral surface to the ascending ramus of mandible. Okay, this is how we put the S-shaped propeller plate. To put that plate, we use the transbuccal trocar cannula and this is how we actually put the plate. Okay, on x-ray this is how the plate will look. Again, bringing the two bones absolutely together, compressing and getting rid of the radio opaque line is not a goal of the treatment. Goal of the treatment is to allow the patient to chew without pain, without mobility, and this is called functionally stable fixation. What we do with mini plates, what we have done here by putting an S-shaped plate on the superior border. Okay, obviously जहां पर teeth है वहां तो आप superior border में teeth के ऊपर तो plate नहीं लगाओगे, तो यहाँ पर आप lateral surface पे plate लगाओगे. But in the angle region here there are no teeth, so you have the liberty of taking your plate to the superior border and fixing it like this. So this is the S-shaped angle plate or a propeller plate, which is how you treat an angle fracture using mini plates. Okay, using the Champy's principles. Okay, so I hope that clears your doubt. The next doubt was TMJ ankylosis. Okay, okay. Doubt number 9 was TMJ ankylosis. Now, I cannot explain TMJ ankylosis completely because it's a big topic. It's not a doubt. All those who want to understand TMJ ankylosis, please go back and watch the videos. Similarly, those who have asked about bilateral sagittal split osteotomy, what is your doubt? This is not a doubt. This is a topic. This is the textbook. There are books on bilateral sagittal split osteotomy. So it's not really a doubt. Go to the videos, watch the videos. Okay, and these are all the doubts that I had till 5 p.m. today. I can see some more doubts. Concept of horizontally favorable and unfavorable fracture, very beautifully described in the recorded videos. Dr. Jyoti, you have the access to recorded videos. There are no shortcuts to success. I cannot give you any shortcut formula. Watch the video, understand the concept, and you will know the answer. Space infection. Space infection is not a doubt. It's a topic. Watch the topic. Ma'am, in casualty, if a patient after RTI comes with heavy bleeding, what should be given as immediate management? So, are you asking me the treatment of bleeding? So, in that case, depends on where the bleeding is from. Is it an oral bleed? Whatever is the source of bleed, you should correct that. So, to answer your question, the thing what we follow is a protocol. We follow an ATLS protocol, and according to that protocol, A, B, C, D, E is the protocol, and C is circulation and hemorrhage control. So you see whatever is the source of hemorrhage, whatever is the source of bleeding. The first treatment for that is control the source. Suppose if it is a fracture which is causing bleed, splint that fracture, do a temporary splinting so that the fracture fragments come together and bleeding stops. Suppose it is a major vessel which has ruptured, catch the vessel and clamp it. That is how you treat the bleed. If it is a nasal bleed, if it is epistaxis, which is due to a nasal bleed because of the Little's area, you pack the nose. You do a gauze pack or do a Foley's catheter pack and pack the nose. Put a pressure pack there so the bleeding will stop. So whatever is the source of bleeding, control the source. That is how you manage bleeding in an emergency. After that, you start correcting the blood loss which has happened. Okay, so that I hope that answers your question. That is the immediate treatment. You can additionally give certain other things. If you're asking me about styptics, you can give tranexamic acid, other things depending on the medical condition of the patient and the requirement. Okay, ma'am, in Warfae's assessment, A is angulation of second molar or angulation of third molar. So Warfae, only remember the full form of all these things, nothing else. Nothing else. It's an absolutely useless assessment of calculation of the difficulty. Nobody is going to ask you anything other than the full form. Don't have to remember anything. Okay. Next thing is gold standard for airway management in Ludwig's angina is cricothyroidotomy or tracheostomy. Gold standard is oral intubation. And it is, I will not call it a gold standard because gold standard उसको कहते हैं कि कुछ भी हो जाए आपको यही करना है. So gold standard beta is not the right term. If a patient has Ludwig's angina, मतलब उसके पूरे neck में swelling है और उसको breathing में difficulty हो रही है, तो क्या आप काट के ही ट्यूब डाल सकते हो? Can't you put a tube normally through the mouth? You can, right? So always when you are choosing an airway, whenever you are choosing an airway for the patient, the first choice is always a non-surgical airway, that is a normal orotracheal intubation. Okay? If you have good resources, if you don't have good resources, use a laryngoscope, watch the glottis, put a tube into the trachea through the glottis. If you don't think that laryngoscope is allowing you, use a fiber optic. If fiber optic is very expensive, it is not available. Oral intubation is not possible. If the oral intubation is not possible, or you have failed to do an oral intubation, then you go for a surgical intubation. And the best surgical intubation is tracheostomy. Tracheostomy is the best surgical intubation. Now, let me just tell you quickly what is cricothyroidotomy. Cricothyroidotomy is faster done and easier to do than tracheostomy because उसके landmarks बिल्कुल ऊपर है. You just have to put a cut and put a tube. It is very superficial. Dissection कम है. Even in emergency, a layman can do a cricothyroidotomy, but it has to be converted into tracheostomy after 45 minutes. You cannot continue with cricothyroidotomy for a long time. Whereas tracheostomy, a person can stay with tracheostomy all his life. And tracheostomy बोलते हैं उसको. ठीक है? So the definitive procedure when oral intubation has failed is surgical, which is tracheostomy. Also, cricothyroidotomy cannot be done in children. Can only be done in adults. Okay, so that I hope that answers your question, anonymous, that which is the gold standard. There is no gold standard. You always have to try an oral intubation first. If you succeed, it is perfect. If you are not able to intubate orally, then you have to go for a surgical intubation, and the best is tracheostomy. Okay, that is all the doubts that I can see here. Rishabh, if we can see the other doubts also, please. If you can just scroll down if there are other doubts. कोई और doubts है? I can only see till bag of bones. Are there any other doubts? This is the last doubt. Is this the last doubt, Rishabh? Okay, so I think all the doubts that you had put earlier and all the doubts that you had asked now, I hope I was able to clarify all your doubts. Remember, I cannot give you a solution to drink that makes you answer all the oral surgery questions. आज जितने भी doubts थे, somehow they were not doubts per se, they were conceptual things. Okay, these are concepts that need to be understood. It is not a doubt. वो होता है कि आपको दो चीजों में confusion है. Okay, these are concepts that you need to understand, and there are no shortcuts. जो चीजें आपको समझ के आंसर करनी है, you have to understand those things and then you can answer. Okay, so just all those who have full topic doubts like TMJ ankylosis or orthognatic surgery, BSSO, space infection, I cannot give you a solution or a shortcut which you can just drink. There is no shortcut. Everything needs to be understood, needs to be read, and needs to be revised. Okay, revise your PYQs, read your explanations, go back to the videos and understand the concepts behind them. All right, Remember, there are no shortcuts to success. Okay, so with this we wind up the doubt session. Our Telegram group is always open for any other doubt clearing. If there are any confusions, this book is telling this answer, that book is telling this answer, those are doubts, and we will be able to solve your doubt. All right, so I wish a very happy learning to all of you. Good night.